referring to. Go to total.
Maybe they mean, doctor, in the previous lecture, I think.
These two.
I think they mean in the previous lecture.
The previous, no, just concentrate to what I put slide and then I figure out it's the time, figure the strength of it. So I just leave it in case if I change my mind, put it. So just concentrate from Salamu Alaikum till Ma Salama.
Okay, tamam. Okay, good morning, everyone. So my name is Maysa Badawi. I'm the teaching assistant. Dr. Khalid is here with us. I will be sharing his recorded lectures, voice lectures, and he will be with us for any questions at the end of the lecture. Okay.
Hi, everybody. I'm Dr. Taiba. I already give you a lecture on Wednesday about...
Everyone can hear when I started?
Yes.
Okay.
Hi, everybody. I'm Dr. Taiba. I already give you a lecture on Wednesday about rhinitis and sinusitis and epistaxis. So, you know, almost I present myself to you again and again. I wish if I could give you in the auditorium the lecture to see you, hear from you. But again, reminding you that if you need any question, you could ask Dr. Shaukat. He will communicate with me if there is any question. And I'm not going to talk in this presentation, which is about pharyngitis, and at the end is the tonsillitis and the management. I will leave the physiology and anatomy. Already you have it in your previous session. The pharyngitis or sore throat, which we commonly say they have sore throat, or it is just inflammation of the pharynx. We call it also strep throat because of the Streptococcus pyogenes. It's also called group A, beta hemolytic Streptococcus pyogenes. This is the most common cause of the pharyngitis and known as strep throat. There is also many viruses and other bacteria which cause the pharyngitis, and it all the countries, this is just studies from USA, 40 million visits in the general practitioner per year, which is quite a lot, and that's take time from people in the work or in the studying or in the school, and that's which going to be similar to what going to present it to you later on about acute otitis media, and it is has a similar pattern of widespread affecting the socioeconomic of any country. The acute pharyngitis, the viral, which is about 42%, adenovirus is the most common virus, 31%. Also, Epstein-Barr virus, influenza virus. Bacteria, we already talk about Streptococcus, beta hemolytic, Streptococci, Haemophilus influenza, Staph aureus, Bacterium diphtheria with the vaccination. It's not like what it was in the past, and anaerobe. Fungal, there is a lot of cases they present to my clinic and miss being diagnosed with the patient have a lot of irritation, itching, and pain. And when we examine them, we will see the white patch of the candidiasis. And that's really not too much compared with the viral pharyngitis or bacterial pharyngitis. But the point which I'm talking about it is just it's a missing diagnosis. The pathophysiology is the invasion of the mucosa with whatever is the pathogens, but basically when it is stripped, local inflammation, irritation, the thing is it goes beyond that. That's produce toxin, and this toxin, as we will see later on for rheumatic fever and affecting the kidney, as well as the myocardium. And here you could see in the slide the M protein with electron microscopic study, which shows the M protein attached to the streptococci. It's just like a tennis ball with the feathering of the M protein. Patients present usually with their clinical features of either mild or moderate infection. They complain of discomfort, malaise, low-grade fever. They feel congested, and there is no lymphadenopathy. This is the normal, which is a pinkish, nice-looking, sometimes pale mucosa of the pharynx, uvula, tonsils. But with the patient had the mild infection of pharyngitis, most likely this appearance you would see it with the viral pharyngitis. But when it is really severe or to moderate to severe infection, when you hear from the patient, they have fever, headache, dysphagia, and when you examine them, you will see these lymphoid follicles. You could see that, and they could also associate with palpable lymph node in the neck. But the condition is getting worse. That in term later on when talk about the treatment will be treated more aggressively. We investigate them by taking throat swab, and that's a lot of clinic. They start treatment, they start antibiotic without taking the culture for swab for culture sensitivity, and that's basically helpful. Sometimes doesn't get anything, especially when the patient already exposed to previous courses of antibiotic. And we do all these tests for to check for beta hemolytic streptococci. With this rapid test is swab for antibodies versus the culture. It is faster but less sensitive. But when the patient really get symptoms like fever, chest pain, fatigue, body ache, shortening of breath, we will do serological testing to look for the antibody, streptolysin O ASO test. Also CBC will show you the white count is high. For the culture for diphtheria, if you have suspicion, but again, this is not as it was like in the past. We do also monospot if there is infectious mononucleosis, and that's the infectious mononucleosis. Obviously, the patient, they get very much systemic disease, not only pharyngitis, but there is lymphadenopathy, enlargement of the spleen and liver. They get headache and they get stomach ache. When you examine them, you see the exudates, the white patch in the pharynx as well as in the tonsil, as well as they also get skin rash. So we do for them, a part of the investigation is the monospot once you get suspicion about them, but you have to time it rightly, which is in 2 to 5 weeks from symptoms which occur, and you could hear from the patient and you examine them. Then you order the test, otherwise it will not going to show you any result. It is immunofluorescent test for IgM, and that's the infectious mononucleosis, a viral, and you do nothing for it, just the rest, and we will talk about it possibly later. For the treatment in general for pharyngitis, it's just bed rest, fluid, warm saline, gargling, analgesics, and to stay not to take a rest from work or at home, to be not in contact, just in case if this is a viral, it could or bacterial could spread the disease to the others. If the thing's getting, as I said before, fever and persist, and the patient is so congested, and you take the culture, but you don't wait for the culture, you start give them first line of treatment is oral penicillin. That's the gold standard. And the second line, when this doesn't work with the patient, or in the second attack, we'll give them now the second generation, like cephalosporin and augmentin, which is amoxicillin and clavulanic acid, all these. But in case of patient had sensitivity to the penicillin or its derivatives, then we give them microlates, which is like erythromycin and clasic. If it recur, we give more, like third line antibiotic. And then at the end, you possibly, when there is recurrent tonsillitis with it, so we go for tonsillectomy. When it becomes chronic or persistent sore throat, it's a chronic pharyngitis, which is different than acute in lasting in a longer time, not responding to the remedy which you give usually for acute pharyngitis. Now, characterized by hypertrophy of the mucosa of ceruminous gland. It is two types, catarrhal and hypertrophic. Mainly when I see the patient come and say, the doctor, I have a lot of sore throat all days, a lot of attacks. First question I ask them about reflux, if they have acid reflux. If they have gastroesophageal reflux disease, which is the most common cause of pharyngitis. Then you ask them about persistent infection, either sinusitis, this is part of it, because when they have also a problem with the dental abscess, chronic persistent tonsillitis. So this is what probably make it chronic. Also, when the patient get mouth breathing, and that's because the dryness and either because of deviated nasal septum, as you could see here in hypertrophy of the turbinates, or presence of nasal polyps, nasal polyposis, sinusitis, so their nose is blocked, so obligatory they need to open their mouth to breathe, and that's lead to dryness and then chronic pharyngitis. Of course, there is also etiology for that, is allergic vasomotor rhinitis, because of its allergy. You exclude all this for children, adenoid, or if there is nasopharyngeal carcinoma. So that's one of the things, indicator. So you look and examine the patient generally. Or they have a chronic irritant exposed to smoking tobacco. That's a third or fourth question I ask, do you smoke cigarette or alcohol? Because this will irritate the pharyngeal mucosa until it becomes a chronic pharyngitis. Environment, which is the dust, the smoke, people, their work, their occupation, the fumes, that will, first thing is the oral cavity exposed to all these irritants, so this will lead to pharyngitis. And of course, voice abuse and patient, they don't have also very sound use for their, because this also affect the larynx as well as the pharynx. Usually the patient come with like discomfort, especially when they wake up in the morning and they have cough, foreign body-like sensation, and voice, they get hoarseness of their voice. When you examine them, you will see the hypertrophied posterior wall of the pharynx. Also, the uvula is congested. and this we call it glandular pharyngitis with the thick edematous mucosa. The treatment, of course, you treat the chronic causes. First is the patient, I refer them to gastroenterologists. They probably, depending on their age, they do gastroscopy and check if there is hiatus hernia, they get ulcer, reflux. So this, once it is treated, this will help them if there is a possibly associated with chronic tonsillitis, so tonsillectomy. And again, the other regimen, this diathermy is hardly being suggested. Usually when they get humidifier, if we treat the nose, if there is a problem with the sinus and diffusion of the septum, these all sore throat symptom will very much improve. And this is the different type, which is the granular pharyngitis. As I just mentioned before, we'll treat their reflex, acid reflex with anti-acid, with the H2 blockers. If they smoke, we need to get them to quit smoking and reduce the stress, reduce their weight, their lifestyle to be improved, their habit, and so on and so forth. The atrophic pharyngitis is another, the extreme, like what when we talk about atrophic turbinates, and that's the same. You will see pink, pale, not anymore pinkish atrophy, secondary to atrophic rhinitis, dryness and dry cough, and you will see pharyngeal mucosa is covering with crust. This is also typical for exposure to radiation for tumor in the head and neck region. Of course, the treatment is to get them gargling and drinking a lot of water, humidification, to treat, to counter the dryness and loss of secreting mucosa. Keratosis phalangitis, which is a benign condition, it's just a horny white yellowish like material on the surface of the tonsil and pharyngeal wall. Patient, they try to clean it, but sometimes doesn't work. It's just to assure them. And some of the patients, they come and they insist because they feel that there is a bad feature, like they don't like their breath, and they may go for tonsillectomy. This is, I will leave it to you to read it. Association systemic disease with the pharyngitis. Always you could explore it more as an exercise for you. Now we talk about acute tonsillitis. We said it's a group A beta hemolytic streptococci, mostly Haemophilus influenza, and also viral, and there is different viruses. As we just mentioned that before at the beginning of the lecture about different viruses, is the same. So here is the normal tonsil, normal appearance. This is not just diagram show you the whites and red swollen tonsil, swollen uvula. The pathogenesis and pathology usually start in the childhood when there is low immune status. So that's why you see recurrent tonsillitis, and most of the tonsillectomy and done in the childhood. Usually people with the improve their immune response, they get less chance to have tonsillectomy. Of course, depending on the disease progress, there is different type. I will go through them quickly. Acute catarrhal or superficial tonsillitis. Here is, as you see, it's generalized pharyngitis, very much edematous uvula and big tonsil, and that's mostly you will see that as it is in the only viral pharyngitis, but here also a viral tonsillitis. Same as the viral pharyngitis, but it's more prominent because the tonsil and uvula is more huge. The cryptic tonsillitis, or we call it cryptogenic tonsil, again, either following viral infection or secondary to bacterial infection, super veins with the entrapped within the organism in the crypts. That's why we call it cryptogenic or cryptic tonsillitis. And you could see when you examine the patient, all these crypts like a cleft inside the tonsil, and the pathogens is already localized itself inside these crypts. The other type is acute follicular. It's the crypts. There is now purulent material. It's further more advanced stage with yellow spots, and you could see also exudate in the tonsils. Membranous, just membrane followed acute follicular tonsillitis with exudate. Of course, this is the stage when there is late presentation of the patient without being treated or treated poorly with the antibiotic, not right antibiotic, not enough time, and not enough strength, and so on and so forth, according to the age and weight. When it's become the organism filling whole and the tonsils, it become uniformly enlarged and congested tonsil, and this is a huge tonsil. After the infection disappear, and there is more chance that this tonsil become big and become obstructive tonsillitis or obstructive tonsil, and that's one of the indication when it is obstructive tonsil, then you need to remove it because it causes also difficulty breathing at night and sleep apnea-like syndrome. Here we go. It's a fever for acute tonsillitis, dry cough, odynophagia and dysphagia. So when you patients swallow, they have pain, and when there is in their pharynx without swallowing, they have this pain. Their signs: bad breath, congested tongue, congestion of pillar, soft palate, and uvula. Also, there is lymph node, and it is common here in the culture. They think the tonsil went down, so they are referring to tender lymph node. They thought this is their tonsil is down, so it's just a lymph node. Infection is spread from the tonsil to the neck, and the tonsil again is congested, as I show you in the previous slides. The investigation is the same as we just talked about in the previous slide, but we add here with the tonsillitis, especially children, from the parents. When you question them, they said yes, the child have difficulty to breathe at night, they snore, they open their mouth, because as you could see, the adenoid is closing the lumen. It's become very narrow, and the shadow of the adenoid seen in the lateral plane X-ray, and you could also see the shadow of the tonsil. So this will make this child is a candidate for adenotonsillectomy, as we're going to discuss in the lecture for otitis media. The treatment is bed rest, a lot of fluids, antimicrobial therapy. We'll give the first line treatment penicillin, and if the case there is sensitivity to penicillin or its derivative like cephalosporin, there is 5% cross immune reaction. So we use erythromycin in place. I usually use that's from my practice. I give them the second line. They do very well with the third generation cephalosporin orally in the form of Omnicef. And that for me, in my practice, I found the patient get rid of the problem and hardly they will continue to take the medication longer than you go to first line penicillin, then second line, and so on. It's a practice and the choice and the culture and the socioeconomic and so on and so forth. People, they come from far away from my clinic. It's and they hardly have very good medical supervision in their area. So that's all, as you as a physician put that in consideration, because it's not all the time as a text what it says. So you need to adapt and modify your practice. The complication from tonsillitis, and this is the route of spread either through hematogenous, lymphatic, or a direct spread. Acute tonsillitis could be repeated later on, become a chronic, then you get maybe so virulent versus the immune of the patient and how much the organism virulence. You in patient with the peritonsillar abscess where the pus comes out and go behind in the capsule and it's become so swollen. These patients usually they're very sick and you need to release the pus. And you could do it, I'm not going to go too much into detail for surgery, but we need to drain them here in this area with a knife under topical and local anesthesia. You don't need to take them to the emergency room unless they are really children and not adult to cooperate with you. Once you drain the pus, they improve very well with the IV at the beginning, then oral antibiotic. But with the cases goes from here to the parapharyngeal space to the spaces in the neck, as we're going to, you have that in your anatomy, then this is a serious situation, need to be dealt with the same as retropharyngeal if it goes behind the pharynx. So you need to be drained under general anesthesia, and you keep the drain out, you give them IV antibiotic. Usually they improve very well. We said about otitis media, that's we'll leave it associated with the acute otitis media, with tonsillitis as well as hypertrophy adenoid, like a triad. Rheumatic fever, which probably had to be not to reach to this when you give them antibiotic. If not do well with it, or they don't have the antibiotic, then you get, as we explained at the beginning, the toxins then make a reaction to the kidney, to the myocardium, mitral valve stenosis, as well as rheumatoid arthritis. The patient, they will be really, could be avoid all that by proper treatment and proper decision to take the tonsil out, the source of the toxin. And this is just little things as a complication, like a cyst or tonsillitis, like a stone in the tonsil. This is more advanced complication, which you go through it. Differential diagnosis, anything with the membrane, membranous tonsillitis could be like, as I said before, infectious meninoclosis, Vincent angina, traumatic ulcer, and malignancy. The chronic tonsillitis, when it becomes so much attack, either acute or subclinical infection. This is also associated with sinusitis as well as dental abscess. The treatment is diet, good oral hygiene, and treatment of associated other infection. Of course, we do tonsillectomy as absolute indication, the biopsy, if there is a suspicion of malignancy or one side is bigger than the other side, when it becomes sleep apnea syndrome, as we mentioned before, when the tonsil become so huge and big, preventing patient from breathing at night, or when there is a second attack of peritonsillar abscess. The relative indication, according to the American Academy, which most of the world is following it with their very huge studies, 6 to 8 week attack per year, that's indication for tonsillectomy, or 4 to 5 attacks for 2 years in successive 2 years, or 2 to 3 attacks in the 3 years. Also, it is access for glossopharyngeal neuronectomy or ossified styloid process. You do the tonsillectomy, or if there is a tonsillar cyst or tenth leaf, or part of UPPP, we say UPPP, it's part of uvulopalato-pharyngoplasty. This is a procedure we do for sleep apnea syndrome. We'll take the tonsil, then we suture the anterior and posterior pillar, take the uvula, and that's to increase the amount of air go to the airway, the lower airway. Also, children with failure to thrive, they don't eat well, the parents come to you and you will find the tonsil. Sometimes they are atrophic, very small, but with its toxin, then when you remove it, this condition will improve. Or if it is, as we said, a septic source for rheumatoid arthritis. Well, surgery, we don't want you to go through that, but there is, just to have idea, we remove the either by bipolar, like in this case, remove the tonsils, and we just keep the pillar, or we do that with the classical surgical dissection with the scissor and knife, or by laser surgery. This is just to give you an idea. We remove the tonsil under general anesthesia. It's a day surgery, usually associated with adenoidectomy with or without laryngectomy tube insertion. Complication of the surgery, of course, we worried about hemorrhage, primary hemorrhage, and this 1 to 2% could be. So surgeon had to, and the parents and the medical center to be ready to deal with this. We take the patient back again immediately, same night. If they bleed, we stop the bleeding by cauterizing or suturing, see what's injury structures. Or secondary, which is 6 to 10 days, most likely because of patient, they don't drink well, and then they get dryness and crust, then the bleeding, or from infection source, then the bleeding start. And usually this with symptomatic management, fluids, and improve the patient all general condition, either in the hospital or most of the time at home, they will be okay. Delayed, which is nasopharyngeal stenosis, too much, especially after the if you do uvulopalato, or again in velopharyngeal insufficiency, or you leave part of the tonsil, but that's usually not very common. Thank you for your attention, and I will give you a few more lectures in the coming near future. Thanks for your listening.
Okay, everyone, any questions for Dr. Khalid?
There is a question, do we have to know the treatment? Hi, everybody. Well, the treatment is part of knowing everything. Like, yes, you need to know the treatment, but not the detail of surgical part of it, just to know there is a procedure called tonsillectomy, as I mentioned in this slide, which is just give you an idea, but not the detail. Of course, the pharmaceutical, once you to know the pathology, the clinical presentation, also what is the management. Yes. Yes, this is because of the acid. Why the gastroesophageal disease cause pharyngitis? Because the acid, HCl, it is only to be inside the stomach. Stomach is designed this way to deal with the acidity, high acidity, but not the pharynx or the esophagus. So this is cause burning sensation, and the patient really came for a pharyngitis. And if you miss that they have reflux, then you are not going to deal or treat it. So you just give them treatment for infection while it is just reflux. And there is a question which I missed, last one. I didn't see it. It went very fast. Any further question, please? Dr. Maisa?
Yes, doctor.
I think there is one question I missed. It was so.
A question you missed?
Well, last one, but anyway, if they could repeat. Well, if there is any other question.
Doctor, nothing written on the chat.
Okay, no, before, I mean, when I was answering, while I'm talking, there was a question, I didn't read it. But anyway, if
I think only, doctor, regarding the hidden slides, the one that you answered already.
Yes, no, you just look at what I present to you.
I can't see anything.
But basically, related back to the question of the treatment, the most important at the stage here, the pathogenesis, the investigation. There is a stress about the bacterial and viral. You know, all the time they ask what is the most common things come in the exam, but this is not the exam. I'm just talking for your life of your practice later on. So you need to make stress on this.
Okay, sure, doctor. Any more questions for Dr. Khalid? I think there is no more questions, doctor.
Thank you, doctor.
Thank you very much.
Thank you, everybody. Bye-bye.
Bye.